So good afternoon, everyone. At the outset, I would like to thank MPSOS for giving me this opportunity, and congratulations MPSOS for getting this award. I'll be talking about cornea and clarity, shedding light on cataract management with coexisting corneal pathologies. So basically, what are the associated corneal pathologies we are talking about? It could be a degenerative pathology, pterygium, a spheroidal degeneration, or a BSK. Then you can have opacity due to trauma or a healed corneal ulcer. There could be high astigmatism, or in case as in keratoconus. And then you have these, the post-refractive eyes with the RK, PRK, and the LASIK done. And at times you have silicone oil, post-vitrectomized eyes, wherein the silicone oil causes corneal degeneration. And then you have systemic diseases. Wilson's disease is very common. And for the dystrophies, there's a huge list. But I would just shift our interest to Fuchs endothelial dystrophy. These are the commonest. And then what are the second thing, which is an ocular surface compromise. So there is just a very fine line dividing this. So it could be because of exposure to keratopathy, that's post-facial nerve palsy with Bell's, absent Bell's phenomena. You can have a limbal stem cell deficiency. You can have contact lens abuse, a neurotropic dry eye, side effects of ocular and topical medications, or trichic acid leading to any corneal degeneration or opacity. And finally, MGD, dry eye leading to distorted Myers with unreliable K values. Now, these are things which have to be really kept in mind whenever you are talking to any patient, because the list which I have mentioned, more than 60 to 70% are going to fall in that, because this is one thing which is, cornea is the next in thing which has to be taken into account. So what do we do? Actually, we should treat the infectious keratitis first, be it bacterial or fungal. SPKs due to adenoviral keratitis need to be taken care of, because SPKs are really, really very notorious. They keep on coming. I mean, the reactivation of SPKs is so common, that has to be taken care of. When it comes to herpetic infections, you need to treat them, and the eye needs to be symptom-free for at least 3 months. And there is a debate on that. There are people who say it could be 6 months or 1 year. But then 3 months is the minimal time wherein there shouldn't be any treatment going on, and the patient shouldn't have any recurrence. Manage the systemic disorder and stop or change the oral or the topical medication that is leading to the corneal changes. And obviously, we need to treat the MGD and the dry eye. That's very important. So what do we do when it comes to a preoperative evaluation? So what I do in my practice is I document as much as I can. So the corneal sensitivity is again very important. There are patients who have issues with the corneal sensation, and we just failed to check that. So this is one thing which we learned the hard way. There were patients who came back with neurotropic keratitis, and we were really shocked. Doctor, हमको तो समझ भी नहीं आता है, हमको तो कोई तकलीफ ही नहीं होती, and then suddenly you find that the patient is having absent corneal sensations. Schirmer and the TFN breakup time are one things which can be done very easily. Slit lamp photographs are needed. Document the layer at fault if we can do that, and it is very simple to do. Once everybody has a slit lamp में हल्का सा zoom करेंगे, slit lamp के slits beam up down करेंगे, you'll be able to find the layer at fault. Pachymetry is important, and the specular microscopy is important. 700 cells per cubic millimeter is at least one thing which is important. Now finally, corneal biomechanics, if all you have an access to Corus, it is very good. And tomo and topography whenever you have any patient with high astigmatism, keratoconus. Now comes the most important part, that is the counseling. Now with the slit lamp picks, the pachy, specular count, tomo and tomography, everything in front of us, we have to ask ourselves first, is the patient fit for, number one, a cataract surgery alone? Number two, a cataract surgery or a combined PK or a lamellar keratoplasty, a DSEK or a DMEK? And if you have a central leukomatous or a nebular corneal opacity, you have to make sure that you mention it very clearly to the patient what the post-operative vision is going to be. Because this patient has come to you with a problem, and if you just treat the cataract and you leave behind a central opacity which is leading to glare at night, or for that matter, a loss of a line of vision, he or she won't be very happy. And make sure that a regular phaco causes around 7 to 10% of the endothelial loss. Now, stress on the visual prognosis and to the patient, so that the patient understands and accepts the probable outcome. Planning a procedure, obviously you need to have a good specular count. Low IOP, slow motion phaco is definitely more acceptable norm. Low power of the phaco is very much important, and using the soft cell technique wherein copious amount of dispersive OVD, just make sure it underlines and it coats the endothelium so that you are preventing any corneal damage. And obviously, if you have major problems in the cornea consultant backup, if you're planning a second or a combined procedure. Now, this is a patient, it's a very old patient. Now, this patient had a BSK in one eye, and the cornea was not very healthy in the other eye. He had very high astigmatism, and he was told a monofocal lens. But as you can see, this was way back. One was done in 2015, second was done in 2016. This patient was given a smart toric lens, and the patient ended up with a vision of around 612. He was very happy. Obviously, gaon wala hai, he didn't mind that. But then leaving a patient with a cylindrical power of +5 or a +10 is absolutely not acceptable, at least on date. We have such smart lenses, and these lenses are not very costly either. The patient is ready to pay for that.
Time is up, Rahul.
Yes, sir. Last case. So now this is again a case of post-LASIK. She had a very poor specular counts. She was counseled very well, probably need for a second procedure. Soft cell technique was used. We did pentacam. As you can see, the specular counts were not very good. We did multiple readings on the Argus as well as the LensStar. We went in for the ASCRS online calculator, and to our surprise, or to our, I don't know what, to our comfort, the patient ended up with a vision of 6.9. 6.6 with a -1 spherical. We targeted the patient with for -1, and this is day 1 post-op. So to summarize, identify the cornea pathology and its cause. We need to treat it if at all, if it's possible. We need to document as much as we can. We need to counsel and explain the plan and need for a second procedure. Combined procedures should always involve a cornea specialist, and low parameters phaco is important with a soft cell technique. Thank you so much for your patient hearing.
Thank you, Dr. Rahul. Nice and elaborate.